Hi, I'm Brandl Stephenson. I'm an educator with CareFlight. Today we're going to be talking about OMI versus STEMI, why we need to change our paradigm and relearn how we interpret 12-lead kgs. So back in 2017, the European Heart Journal published a meta-analysis on STEMI, which found out that we have been consistently misdiagnosing or underdiagnosing cardiac occlusive events. Up to 30% of patients that go into the hospital for an STEMI are actually having a fully occlusive event with TIMI flow grade 0, the cardiac occlusion in various overt arteries. For a lot of people, this has become unacceptable, and it should be unacceptable for us as well. Up to 30% of our STEMI patients are being misdiagnosed. OMI criteria addresses this. OMI stands for occlusive myocardial infarction, and it was first developed by Dr. Stephen Smith back in 2018. He and his colleagues have come together and introduced a list of STEMI equivalents that have now become the criteria or paradigm that we're going to use to relearn our interpretation of 12-lead EKGs. Some of these things include hyperacute T waves, subtle ST elevation less than a millimeter underneath lead, reciprocal depressions, de Winter's pattern, posterior OMIs, Wellens syndrome, AAMB, QRS distortions, they do. And ST elevation in AVR. As we all know, AVR is often being referred to as lead of no consequence, but we find out now that it has a significant role to play in OMI interpretation.
This will be part one of a multi-part series that we'll be rolling out for the next few months. Today, we're going to sit down and cover primarily 4 OMI and no STEMI equivalents. These will be Wellens, hyperacute dynamic T-wave changes, de Winter's pattern, and posterior EKGs. We're also going to go into considering and looking at specific patient presentations and EKGs.
Sounds good. Wonderful. Now give me a finger gun. Cool.
All right, so like we talked about earlier, we need to shift our focus from millimeter interpretations of STEMI and look more towards arterial occlusion. So how do we do that, given the fact that what we're looking at is the printout from a giant oscilloscope, which is basically what a monitor is? We shift away from ST elevation and we start looking more at T-wave morphology. That's kind of become the main criterion for a lot of these OMI indicators. Hyperacute T waves tend to become one of the first indicators that you get when you're trying to interpret a 12-lead based on OMI criteria, on the OMI paradigm. Hyperacute T waves differ from hyperkalemic T waves in that when you're looking at a hyperkalemic 12 lead, you're looking at narrower, steeper, sharper T waves, usually accompanied by additional hyperkalemic symptoms like bradycardia, widened QRSs, things like that. Plus, you look at your past medical history, your past injury patterns, and injury pattern history. And does any of that lead you to believe it's a hyperkalemic episode? If yes, treat accordingly. If not, if you're looking at normal heart rhythms and heart rates, but you're looking at a very broad-based, very wide T wave in relation to your QRS segment, you're probably looking at these hyperacute T waves, which are an early indicator of cardiac occlusion. Again, this occlusion can be anywhere from a TIMI flow of 1 or 2 all the way to 0, where you've got nothing flowing past that. And there's no indicator outside of that hyperacute T wave. So your patient may be pain-free, it may be in diffuse leads, but it is something to consider when you're looking at a 12 lead initially. If you do see tall peak T waves, don't automatically dismiss it as hyperkalemia. Is it bradycardic? Is it a widened QRS? If not, you may very well be looking at the first injury indicator of an occlusive MI. The next thing that we want to look at is Wellens syndrome. Wellens syndrome is interesting in that it's primarily found in V2 and V3, V3 being more prevalent. You have 2 varieties of Wellens syndrome, type A and B. Type A Wellens syndrome, you're going to see more biphasic T waves that alternate up and down the isoelectric line. Type B, you'll see inverted T waves where it drops down below the isoelectric line. Both of these are, again, indicators for immediate cath lab activation. And when we're talking about T-wave morphology and T-wave size, we need to keep in mind proportionality as well. OMI shifts away from, like I said, measuring things. Now we're looking at it in relation to the overall QRS. So if I'm looking at the patient's QRS and it appears to be relatively low amplitude but within normal parameters, what does my T-wave look like when I compare it to that? Does it look like something that would match that QRS complex, or does it appear to be out of proportion? Is it a very widened base? Is it a very tall and broad peaked T wave? Is it biphasic in V2 and V3? Is it downsloping? These are inverted. These are things to consider when you're looking at your 12 lead and utilizing OMI criteria or paradigms versus STEMI paradigms.
Now discussing typical and atypical presentations within OMI. So often with these patients, you may have your typical patient, slightly older, history of cardiac or MI involvement. You still might find your chest pain, your discomfort. You might have your sudden onset or gradual onset, shortness of breath. They might appear diaphoretic. You can have nausea, vomiting still, syncope, near syncope. And these are all, of course, your typical presentations. Now included with OMI is the high-risk patient, and they're more often atypical presentations. So rolling into these, oftentimes you'll find elderly patients with non-specific complications or concerns or chief complaints, and you can have just generalized weakness, maybe a little bit of confusion, a prior syncopal or near syncopal event, and instead of your more typical chest pain or shortness of breath or abdominal pain. And of course, women more frequently report atypical symptoms such as generic nausea, maybe fatigue, a little bit of dyspnea, and then of course your abdominal discomfort. Also, patients with diabetes will oftentimes present with blunted or silent ischemic symptoms just due to their autonomic neuropathy. And then rolling in with patients who do have more significant cardiac history, your CABG patients, your chronic respiratory patients. They may have very subtle or non-classic presentations, and you should maintain a high risk of suspicion with these guys. And of course, your key physical exam findings that roll in with all these patients: hypertension or shock should clue you in, tachycardia, bradycardia, arrhythmias, new heart sounds such as S3, and pulmonary crackles, jugular vein distension also might lead into acute heart failure. Now we're going to roll into additional known or named signs for OMI, such as the D. Winters T wave. D. Winters was found and evaluated in the 40s and is now considered an anterior MI equivalent. Criteria for D. Winters are tall, prominent, symmetrical T waves and precordial leads, your V1 through V6. You'll also have upsloping ST segment depression greater than 1 millimeter at the J point in your precordial leads. You might also find absence of ST elevation in your precordial leads. Reciprocal ST segment elevation, generally 0.5 millimeters to 1 millimeter in AVR. And of course, typical STEMI morphology may precede or even follow the D. Winters pattern. So D. Winters is associated most often with LED occlusion, and it has been associated also with a lower risk patient demographic. Generally, your males in their 40s with no major cardiac history, no major medical history, who are now complaining of typical or atypical cardiac symptoms. These patients are also at very high risk of sudden cardiac arrest if D. Winters is identified. And then touching on D. Winters even more, it can be confused with hyperkalemia in the field, of course, without labs or any associated lab findings. So really diving into your real good patient history, patient assessment to differentiate between HyperK and D. Winters is critically important to make sure you're going down the right track and you're treating the patient appropriately. Continuing on, with more identified OMI equivalents or STEMI equivalents is, of course, your posterior MI pattern. Posterior MI is suggested by the following changes in V1 through V3: horizontal ST depression. You have tall, broad R waves, generally greater than 30 milliseconds. Upright T waves. You can also have your dominant R wave or an R to S ratio greater than 1 in V2. This is confirmed with a posterior 12-lead placement, which, to go over real quick, the posterior is essentially your V7 through V9. Your V7 will go along your posterior axillary line in the same horizontal plane as your V6. Your V8 will be at the tip of the left scapula in the same horizontal plane also as V6. And then your V9 will be placed in your left paraspinal region in the same horizontal plane as your V6 also. Once you have completed a 12-lead, you may have ST elevation that confirms your posterior. It's considered a STEMI.
Okay, to draw some graphics to illustrate our hyperacute T waves versus normal T waves, you can see here in V2 and V3, this will be your normal T wave over here on this side. Remember, everything is in relation to the QRS. It's not based on millimeters, how many small boxes, how many big boxes. It's in relation to the patient's QRS. So when we're looking at these T waves, you can see that with a normal T wave versus hyperacute, they both have this pretty much the same amplitude. But when you look at them in relation to the preceding QRS, a normal T wave, you can see here's your QRS, and then here's my T wave, and it falls within parameters for a normal T wave. When I compare it though to this QRS, which we're defining as hyperacute, with a proven left anterior descending OMI, we see that it's out of proportion to our QRS. It's much broader, it's much longer in duration. So in the absence of any other signs and symptoms of hyperkalemia, you should feel confident or comfortable defining this as a hyperacute T wave, which could be indicating an occlusive MI event. To help further illustrate that, this is the difference between a hyperkalemic T wave and a hyperacute T wave. Hyperkalemic T waves, we've got the Eiffel Tower. This is a great illustration for what a hyperkalemic T wave looks like. Narrower based, sharper peaked, still tall in relation to our QRS, but we're also looking at other signs and symptoms of hyperkalemia, such as a widened QRS, a bradycardic rate. Whereas when we look at a hyperacute T wave, think more Capitol building, broader base, a bit more of a rounded top, and vastly out of proportion to the preceding QRS. That also brings us over here to Wellens syndrome. So you can see here with Wellens syndrome, when we're looking in V2 and V3, we're looking at which way is our T wave deflecting. Here in V2 and V3, we see that it's deflecting negatively underneath the isoelectric line. In the absence of anything else, that's going to be defined as Wellens syndrome, which is again a criteria, OMI criteria, that meets cath lab activation criteria. So when you see something like this, and your patient may be pain-free. They may have had a cardiac event, 2, 4, up to 12 hours prior, where they had some chest pain or shortness of breath or chest pressure, what have you, and now they're pain-free. You get there, you put them on a 12 lead, and you see in V3 you have some negative deflection in your in lead V3. That is going to be a Wellens type B criteria for OMI, and that does merit cath lab activation. You can see here in V4 also we have negative deflection. All of these things are kind of a stair step that build towards actual ST elevation MI. It may be 8, 10, 12 hours later down the road, but when you start seeing these early warning signs, hyperacute T waves, De Winter's T waves, Wellens syndrome, or Wellens signs in V2 and V3, when you start seeing these, they all start to stair step and build on one another until finally you are looking at the textbook classic definition of an ST elevation MI.
Continuing on with our STEMI equivalents, right here we have a De Winter's T wave 12-lead example. Rolling right into our diagnostic criteria, right, we're going to have our tall, prominent symmetrical T waves in the precordial leads. So you're going to look and evaluate your V1, V2, all the way through your V6. You look for these tall, prominent T waves. And this one is an excellent example. We have numerous that are pretty clear and stand out. You'll also find your upsloping ST segment depression, generally greater than 1 millimeter in the J point. Also in these precordial leads. So you'll find your J points, evaluate, well, you have maybe that 0.5 to 1 millimeter change.
What this you?
And then rolling on, you'll also find you have general absence of ST elevation in your precordial leads. And then switching on over to your AVR, you will find your reciprocal elevation changes in your AVR. If you find over here, it's quite subtle, but it's generally maybe 0.5 to 1 millimeter. That doesn't typically match any other STEMI criteria, but it is found here. And then typical STEMI may even follow this pattern, as well as sudden lethal arrhythmias. Moving on over to our posterior. The posterior one is not too significantly difficult to identify if you know what you're looking for. Moving on over to our posterior MI, using a 12 lead or a typical 12 lead, you're going to evaluate your precordial leads again in V1 through V6. You'll find in your V2 your horizontal ST depression. Here this is very obvious with your ST depression. You're also going to have your tall, broad R waves, generally greater than 30 milliseconds. You still find you have upright T's, so you'll have that very obvious ST depression, but with your positive T's. And then moving from here, you may even find a dominant R wave, which is generally a ratio greater than 1 for the R to S in V2. And then to confirm the posterior, you're going to have to perform a posterior 12 lead. So then moving your precordial over to that V7, V8, and V9, as seen here in the graphic, along that same plane, typically either V8 directly below that scapula, or V9 in that small back area. And then switching back to your 12 lead, you'll find you do have ST elevation that does meet STEMI criteria. That's all we got on this end. All right, that concludes our presentation today. Remember, this is part 1 of our multi-part series. Today we hit 4 primary OMI or STEMI equivalents. We hit deep winners, Wellens, the posterior changes, and our large dynamic T-wave changes. Next, we're going to go over 3 additional OMI or STEMI equivalents. We're going to get into more patient or case-specific scenarios, evaluate more 12 leads, roll more into evaluation for us in the field. Thank you.